Welcome back, everybody. This is our podcast with Dr. Danny and
Hello.
Dr. Chaitanya. Hello, everybody. So we are going to discuss about adrenal insufficiency and hyperaldosteronism. So I will start with the Dr. Danny. So
Adrenal insufficiency, this is also called Addison's disease.
yeah,
Hyperaldosteronism is a Cohn's disease.
yeah,
Adrenal insufficiency would be in a insufficiency of adrenal hormones.
Yeah.
Basically, adrenal hormone consists of glucocorticoid, mineralocorticoids,
yeah,
and sex corticoids,
Yeah.
GFR.
yeah.
By adrenal insufficiency, we would mean mainly cortisol deficiency.
Yeah. So basically, you just tell me about the told me about like syndrome associated with the primary adrenal. Can you just tell me about the syndrome associated with the primary adrenal insufficiency? What is the syndrome that is associated with the adrenal insufficiency? Adrenal insufficiency basically the what are the symptoms that can be associated with the this adrenal insufficiency?
Interesting. There was Frederick's Waterhouse
Syndrome.
syndrome.
That is actually the
that
this
is
is
the
the
acquired condition.
yeah.
That was the second
The
condition. You mean to
meningitis,
say from
some syndrome.
more of a genetic perspective.
Yeah, yeah.
In fact, I'm
So-
very sorry to say that I couldn't recall exactly.
Yeah, so just these are this autoimmune polyglandular syndrome. Do you know the autoimmune polyglandular syndrome? There are two types, type 1, type 2. These both two types are associated with the this primary adrenal insufficiency, and there is one syndrome called the triple A syndrome. You know, triple A syndrome.
Triple A syndrome.
And these three syndromes are basically associated with this primary adrenal insufficiency.
Okay.
So,
AIPGN 1 and
yeah.
2.
and can you just say like what are the manifestation of the glucocorticoid deficiency and the mineralocorticoid deficiency? In short, can you just say like if like a glucocorticoid deficiency there is the hyponatremia? Yeah.
In mineralocorticoid deficiency, there would be hyponatremia.
Yeah, this is yes. I want to say this is the actually the common feature. We just think like if a mineral corticoid there is a hyponatremia. Thing is that the sodium water is not retention means it's going on the urine, so there is the hyponatremia. But thing is that the glucocorticoid and mineral corticoid both has the same tendency. Yes, means not act parallelly, but thing as the both has this type of the actions can lead to the if deficiency the hyponatremia. But thing is that we have to differentiate by the postural hypotension is both has the postural hypotension. What do you think? The both has also the same feature of the postural hypotension.
Both mineralocorticoid,
Yeah.
even glucocorticoid deficiency can
As
present as
postural
postural hypertension.
Hypotension.
Okay.
But thing is that if there is a hyponatremia, though there is a hyponatremia in the glucocorticoid deficiency, there is no salt craving. But in mineralocorticoid deficiency, there is salt craving with the hyponatremia.
Okay.
Yeah, but in glucocorticoid deficiency, there is fever, but no fever in the mineralocorticoid deficiency. So hyperkalemia feature is present in the mineralocorticoid, but not in the glucocorticoid.
Hyperkalemia?
Yeah.
Yes.
Though both have the hyponatremia thing, but thing is that hyperkalemia feature is only with the mineralocorticoid.
Okay. Essentially, the mineralocorticoid burden is carrying with
Potassium thing.
Potassium thing. Yeah.
Okay. So Addison disease, the most commonly implemented test is which is the most commonly implemented test? Can you say the Dr. Dan?
Incremental test.
Yeah, implemented test. So say okay, this is the Addison disease. I have to say this test like
Glucose challenge or some cortisol.
STS stimulation test you can perform.
Okay.
That's the implemented test.
Implemented test.
Yes.
Okay. What do we do here?
We do like SCTS. We give the SCTS outside, then it will the maybe it will stimulate the SCTS stimulation test. I don't know exact how we perform. Like its name is SCTS stimulation test.
Okay. We basically, I think that we are looking into the central cause in like intracranial cause. If you
for the adrenal
insufficiency.
insufficiency.
It is like that, I guess.
So adrenal insufficiency, the pituitary MRI indicated if you say if patient has the adrenal insufficiency with the normal renin and aldosterone level, So means if there is a renin level and the aldosterone level is normal, though there is a adrenal insufficiency, then the pituitary MRI is indicated. This is called as the primary adrenal insufficiency. Sorry, this is for the secondary adrenal insufficiency. We are searching for the pituitary cause. But in the secondary primary adrenal insufficiency, there is the like high SCTS. We just perform the SCTS stimulation test. So if high SCTS and there's high renin and low aldosterone means the primary one. If like normal renin and aldosterone, we jump for the secondary cause and then we perform the MRI for the secondary adrenal insufficiency. So most common cause for the mineralocorticoid axis. So what is the most common cause of the mineralocorticoid axis, sir? Let's suppose there is mineralocorticoid, excessive mineralocorticoid inside body. So what could be the cause for that excessive?
SCTS is SCTS secreting tumor, maybe.
Just not ACTS. It's like adrenal hyperplasia. This is bilateral micronodular adrenal hyperplasia. So if the micronodular adrenal hyperplasia is there, so that can cause the this is the adrenal that can lead to the mineralocorticoid excess in the patient with the bilateral micronodular adrenal hyperplasia. So we have a very famous and very hit and most prevalent disease, the diabetes mellitus. We are jumping for the diabetes mellitus, sir. So basically we discuss about types, clinical features and the management. So what is the concordance between the identical twins in the type 2 diabetes mellitus is how much percent? You have to say like 70 to 80% of type 2, but type 1 is only 40 to 60%. This is for the this is a clinical feature. These are the clinical presentation between identical
type
twins.
2 how many percent?
It's 70 to 80%, and type 1 is only 40 to 60%. So in
there were HLA association also, no?
Yes.
Some HLA association that were asked previously.
Yes. So in type 2 diabetes mellitus, increase in the fasting plasma glucose level is predominantly due to the increase in the hepatic glucose output.
Okay.
So what is MODI, sir?
Maturity onset in diabetes in young. That is MODI.
MODI. So what are the types of the MODIs?
There are almost 6 MODI. 6.
Yeah, I think I know about 5. So this is the most common type 1 is a type 3.
Type 3, which is hepatic some factor.
No. This is a type 3. Yes. HNF mutation. This is the hepatic nuclear transcription factor. 1, 3 and 5 is due to the hepatic nuclear transcription factor mutation. And type 2 is due to the glucokinase mutation, and type 4 is due to the insulin promoter factor.
Type 2 glucokinase, that would be asked.
Yeah. Type 4 is due to the insulin promoter factor 1 mutation. If type 4 is there, the promoter factor type 1 is mutation. Type 2 is the glucokinase 1, 3 and 5 as the HNF mutation. So what are the clinical presentation? There is the insulinopenia in the MODI. There is insulopenia. There is no insulin. Means basically type 2 there is insulin but resistant. But in MODI there is the insulopenia. There is no insulin. So
this is more resembling towards 1, no?
Yes. So it has so good response with the sulfonylurea. So if you say like this is MODI, you have to prescribe the sulfonylurea because there is the sulfonylurea itself is the secretagogues. It can increase the
insulin secretagogue.
Yeah. So in sulfonylurea is a drug of choice. So there is another type of the diabetes called the latent autoimmune diabetes in adults. This is called the LADA.
Oh my god.
This is LADA. LADA is the form of the type 1 diabetes mellitus of the adults. This is the more type 1.
Okay.
Latent autoimmune diabetes in adult is the LADA.
Autoimmune
diabetes is the LADA. So there is the drugs which pose a risk of the hypoglycemia. Do you know some drugs that pose the hypoglycemia using the diabetes?
In diabetes, we should actually recall the weight gaining and weight weight gaining and weight no effect of weight, such that There are some drugs with
causes the
hypoglycemia. Insulin would be.
Insulin the first.
Insulin sulfonized urea would be.
Insulin secretagogues like sulfonylurea
would be hypoglycemia.
Yes. Other are natigliteinide and repagliteinide also causes. So those drugs which can't cause, which does not cause the hypoglycemia, the like metformin, alpha glucosidase inhibitors, acarbose, and pioglitazone, and DDP4 inhibitor like sitagliptin. These drugs never causes the hypoglycemia. So, Dr. Dennis, so what are the drugs can be used in the both type 1 and type 2? Do you know some drugs that can be used in the both type of the diabetes?
There are only one is new drug. There are only, I guess, just 2 drugs.
Like
one is recent. Type 1, type 2, both can be used.
There's one drug called as insulin.
Insulin, yes.
Another is a primylnitide, enhances the amylin secretion, primylnitide, and another is acarbose. These 3 drugs can be used on the both type of the diabetes. So, do you know, I'm always confused with the ultra short acting and long acting. Can you memorize these things very easily? Do you have any some sort of the easy ideas so that we will easy memorize the thing?
Ultra short and short, no?
Ultra short and long acting. There are 2 names. I'm always confused. Like it's detamir, glargine and glucine.
Glucine and
glargine. So means glucine is this is the ultra short, but glargine is the long acting.
Okay, thank you.
And the intermediate, everybody knows.
Ultra short and short.
Ultra short and short one is the regular insulin. Ultra short I just told you like aspartate and glucine and lispro. But long acting is determine, glargine and the devugludec. So do you know that these 2 phenomena in diabetes is called as a Dan phenomenon, Somagai phenomenon? What is basically what one thing that can differentiate between the Dan and Somagai?
One is early morning.
Both has a early morning hyperglycemia.
One is due to response to the cortisol, pertaining to cortisol. One is due to pertaining response due to high glucose in the previous meal.
Yes. Thing is that one has hypoglycemia, one does not have
hypoglycemia. Outcome.
Means at last outcome is hyper. Both has a hyper. But in 3 a.m. or
before beginning the
hyper
incident,
either one has a hypo one has the it's persistently same level.
Means the cortisol wala chain.
So means you know the guy.
I know the guy.
Guy is a cow.
Okay.
Cow eats something means it is hypo. Okay. So means Somagai is basically Somagai has a hypoglycemia at 3 a.m.
Guy is the Mahamari is a bokmari. Guy is always hungry.
But thing is that at 3 a.m. if you check with this Dan phenomena, there is a normal glucose. But with the Somagai at 3 a.m. there is hypoglycemia. After that, both has a incident for the hyperglycemia. One is due to the cortisol thing. Hypoglycemia, body is stressed and the cortisol is released and it will cause the hyperglycemia. One has the another also the
guy is hypo.
Guy is hypo, but at last both are hypo.
Hyper.
But how would you treat these 2 patient conditions like? See, if patient has a Dan phenomena, means it has a normal glucose at 3 a.m.
but early
morning hyperglycemia. So basically you have to increase the night time this long acting insulin. So in night time you have to increase the insulin dose of the long acting insulin. Means you give a long acting insulin Dan phenomena, but in the Somagai phenomena decrease the night time insulin. Means insulin is the more, so patient is gone on a hypoglycemia. So you give the long acting insulin, but night dose is decreases for this Somagai, but nighttime dose is increasing in the Dan phenomena. So insulin resistance is said to be have developed when the required insulin dose is more than 200 units per day. It's called as the insulin resistance. So what is the problem for the metabolic problem in the patient, the diabetes? Increases the activity of the hormone sensitive lipase and decreases the activity of the lipoprotein lipase. This is basically what the diabetes mellitus does to body.
The whole picture lies around this, no?
Yes. So means if the hormone sensitive lipase is increased, so it is increases the free fatty acid in the plasma. If decrease in lipoprotein lipase means that there is the hypertriglyceridemia. These are there is the presentation of hypertriglyceridemia. Basically diabetes.
Insulin is the catabolic.
Yeah. Catabolic hormone.
Catabolic hormone.
So means there is a increased activity of hormone sensitive lipase and decrease the lipoprotein lipase activity. So if lipoprotein lipase activity decreases the hypertriglyceridemia, if increases causes the there is the free fatty acid in the plasma. So by this I want to jump in the another very important topic, sir. Do you know the reproductive endocrinology?
Very interesting.
Very interesting. You love it. So basically, what is the most common cause for the hypertension in the patient with the adrenal hyperplasia? What enzyme deficiency lead to the hypertension in the patient with the adrenal hyperplasia? So there is 17 alpha hydroxylase lead to the hypertension, and the blood level of the 11D corticosteroid is increased.
That is potent
corticosteroid.
Mineral.
Yeah, potent 11D cortisone. So the best possible method for the clinical management of the hypoglycemia in a girl child with the congenital adrenal hyperplasia is what is the best possible management? So what would you like to give? Like
we would give intrapartum dexamethasone.
Yes. I'm surprised with the basically we used to give the dexa. But thing is that the hydrocortisone, latest one is the hydrocortisone we can give.
Okay, this is not new revision. Okay, we can give hydrocortisone, CH.
So I think this is for the clinical management after if patient deliver with the congenital adrenal hyperplasia, then its treatment is hydrocortisone. What do you think, doctor?
That is that one after the symptom. That is a symptomatic symptomatic treatment conditions.
That's for that condition. I think the hydrocortisone for that condition.
But we used to give the mother, na?
Mother during intrapartum is we'll give dexa. Dexamethasone before the this sex determined. So after like best possible method for the clinical management of the hypoglycemia in a girl child with the congenital hypoglycemic girl child with the congenital adrenal hyperplasia means it is already delivered and the girl child is there.
We need rapidly acting. We should rapidly acting. And
so for this hydrocortisone drug of choice.
Okay.
Can you say this the karyotype for this baby, girl baby?
Ambiguous. What was that? That was some table in that chart.
Karyotype for the patient or the endogen insufficiency syndrome is
AI.
AI is a 46X.
46X name.
XY.
XY.
It's male.
It's I used to recall it as a beautiful male.
So but karyotype is a male. But phenotype is a female. So karyotype is the 46XY. So hypogonadotropy. What are the causes for the hypogonadism? Can you just tell me the few causes for the hypogonadism? Hypogonadism.
These are
hypergonadotropic hypogonadism. One is the hypogonadism. Both hypo, one hyper, one hypo.
Hyper was the gain of function.
So hypergonadotropic is basically the Klinefelter syndrome. Hypergonadotropic hypogonadism, and hypo is a Kalman. Both hypogonadism. So
basically the Klinefelter patient cannot take part in the sexual activity, no? that kind of thing.
Yes,
he has that Klinefelter patient would have small penis.
Yes.
Blah, blah, blah.
Yeah, testis also the atrophies testis, I think.
Atrophic testis.
Yeah, so the response will be increased, means there is no androgen. The central response is always increased, means the hypergonadotrophic, but the testis is not produced, means the hypogonadism. So means this is the Klinefelter.
In Kalmans, there is a
central problem. The hypo means below also hypo. So both condition is the hypo is a Kalman syndrome. So Kalman syndrome basically X-linked disease. X-linked, and the deficiency of the gonadotrophic release GnRS is the deficiency. So anosmia and the hyposmia is there in the hypogonadotrophic hypogonadism. So a few we'll talk about the complication in the next podcast. So thank you everyone.